Electronic health records are being linked by many countries for medical research. The UK has the benefit of a population-based National Health Service in which nearly everyone is registered with a general practice. General practices have been using electronic health records for many years, and these have been widely used in research, but the recent linkage of general practice records with other data sources means that they're even more valuable for research. An important question posed by the linkage is how an event is mapped in each of the sources, and we already know from 2 and 3 source comparisons that an event recorded in one source is not necessarily found in another.
Our study looked at the recording of fatal and non-fatal myocardial infarction in 4 record sources in England, in death registrations, in general practice, and hospital episode statistics, and the MyNAP registry of acute coronary syndromes. And we were surprised to find that only a third of non-fatal myocardial infarctions were recorded in the 3 sources where we would expect to find them, in hospital and general practice and in MyNAP. This means that if we only use one data source, we'll underestimate the total number of people with acute myocardial infarction in England.
We used a research dataset from the Calibre programme, which links 4 sources of health information on over 3 million people in England. It contains general practice records from the Clinical Practice Research Data Link, which give us longitudinal medical and drug history. It also contains hospital episode statistics with ICD-10 coded hospital diagnoses and dates of admission and discharge, the MyNAP National Registry of Acute Coronary Syndromes, which has detailed information about the diagnosis and treatment of myocardial infarction, such as coded ECG findings and troponin measurements, and finally, the National Death Registry, which contains date and cause of death.
So we counted 9,500 patients in the MyNAP registry who had a non-fatal myocardial infarction during our 7-year study period. When we added hospital episode statistics, we found just over 5,000 additional cases. And when we added the general practice data, we found about 3,000 that weren't in either the registry or the hospital data. Overall, only about 31% of non-fatal myocardial infarctions were recorded in all 3 sources. A crucial question is whether we can trust the myocardial infarctions that we find in each of these sources. We looked at this in 2 ways. First of all, we compared the age distribution and the risk factors for such as smoking and blood pressure and cholesterol for myocardial infarctions found in each of the sources, and we found that they were quite similar. And secondly, we also looked at the long-term survival over a year, and again found that they were similar and they were what we would expect for acute myocardial infarctions.
So we're at an early stage of inquiry here, and I think there are a couple of important opportunities. One is to look at the text that general practitioners record about myocardial infarction. A second opportunity is to go back to the detailed clinical records kept in local hospitals. The government in the UK and internationally are increasingly interested in using electronic health records for research. One important area is using these records for outcomes assessment, for example in the UK Biobank cohort, and also outcomes assessment in clinical trials. I think these findings are important for 2 reasons. Firstly, for health systems that care about measuring morbidity and outcomes, our findings suggest the importance of linking up different sources of health records. Secondly, for research, major initiatives such as UK Biobank, randomized controlled trials need these types of data to assess outcomes over follow-up.